Welcome to Beyond Extraordinary, brought to you by LCMC Health. We are an 8-hospital system providing health, care, and education to the greater New Orleans area. We're a health system with 2 academic medical centers, and our academic medical center status means that we have our finger on the pulse of the latest treatments and technologies in medicine, and we're bringing it right to our community. I'm your host, Kristen Gradney, Chief Wellness Officer for LCMC Health. September is National Prostate Cancer Awareness Month, and today we are joined by a true expert in this field, Dr. Oliver Sartor, Director of the Transformational Prostate Cancer Research Center at the East Jefferson General Hospital Cancer Center. So thank you so much for joining us today. We're so excited to have you and just really interested to hear more about you and your journey here to LCMC Health and all of the great things that you've done for prostate cancer and how it's transformed so many lives. So tell us a little bit about yourself and how you got here.
Oh, gosh. First of all, I'm from Louisiana. And second of all, I spent a lot of time in New Orleans. I did my medical school in New Orleans at Tulane. I did my residency in internal medicine here at Tulane. And then I came back after I finished my fellowship and some additional time at the National Cancer Institute in Bethesda, Maryland, to LSU. And I was on LSU faculty for, at least 12 years.
Okay.
I was actually the director of the LSU Cancer Center and chief of hematology oncology. Maybe a little infamous period for being the chief of oncology at Charity when Katrina came in. Yeah, that was exciting. And then left and came back as medical director of the Tulane Cancer Center and professor at Tulane. And did that for 15 years or so. And then went to Mayo Clinic, and now I'm back. So I guess I keep coming back to New Orleans because I like to be here.
Yeah, there's so many great reasons to be here, right? And we're grateful to have you in our city because we know that prostate cancer is so prevalent here and across the country. And I know that there's really great work happening at the Transformational Prostate Cancer Research Center. Could you share with us a little bit about what that means? What are some of the focuses? What is some of the work that's happening that will be truly impactful to our community?
Well, we're just at the beginning. So I've only been here about 9 weeks. So I have more of a vision and an aspiration than accomplishments here and now. But what I'm going to say is the vision and aspiration is to be able to help men live longer and live better, and to be able to find prostate cancer earlier when it can make the most difference. So even before I arrived, we actually did some PSA screening tests, and we did it as part of a fun and sort of activity raiser. We had the one-man shoot, which is a sporting clay shoot that raised some money and awareness about prostate cancer. We had free prostate cancer screening there, supported by the LCMC system, and that was very important. We have aspirations to open many new clinical trials that will help to address unmet needs in prostate cancer. I'm very excited about one now that will have better imaging for the detection of prostate cancer. And it, of course, is a trial that has to be carried forth and maybe submitted to the FDA, maybe submitted to have FDA approval. So we get hopeful with things like that. Of course, we have new therapy trials. We're trying to offer new therapies for people who have advanced prostate cancer. So we're going the whole spectrum, all the way from screening to be able to look at better detection, to be able to look at better treatment, and to put that together as a package. So that's kind of my big vision, and we're making progress.
Sure, what a big vision. But I think you're the right person to do it, and I think that this is the right place to do it. So again, we thank you for being here in the community and really trying to transform the work that's happening and let it be truly impactful to all those.
Let me say a thank you because, I couldn't do it without the coordinated efforts with LCMC and others. And when I sat down with the LCMC leadership team and I began to outline what I hope to do, extremely supportive. So the LCMC leadership has provided me with the tools and resources that I think will help me enable my vision. So that's really exciting.
Sure. Truly a joint effort. Right. So I know you've talked a little bit about the work and what will be happening, but tell us a little bit about the why. Why do we need to think about this? Talk about the prevalence here in Louisiana. What are some of the contributing factors that have us at the rate that we are with prostate cancer? So how do we communicate that to our listeners?
Yeah, so let's start nationally, actually. And, it's an interesting statistic and not one that's great, that if you do not smoke and you're an American man, the leading cause of cancer is prostate cancer.
Wow.
And so it turns out that it's a really big problem. We're losing about 35,000 men a year in the United States. It'll be about 300,000 men diagnosed. It's a confusing disease. I'll tell you what's confusing without getting into all the details. Some men can just be observed and not even treated. And other men, of course, require aggressive treatment from the very beginning. And sorting all that out is very confusing to patients because some men say, well, I don't want to do anything, I feel fine. And other men say, well, wait a minute, don't we need to do something now and yesterday because otherwise this cancer is going to grow and kill me. So we have to separate out those tumors and treat the right patient at the right time with the right therapy for their problem. And that's part of the art form here. Getting back to the big Louisiana problem. Louisiana problem is a little worse than average, but not terribly worse than average. As it turns out that some of the risk factors for prostate cancer are important in Louisiana. We have a relatively high minority population, African-American men. African-American men are at higher risk for prostate cancer, and most importantly, higher risk of death from prostate cancer, about double the risk of death. So African-American men need a special attention to the details when it comes to diagnosing and treating, and we have to get prompt. We don't want to be delayed, and I prefer that we find the prostate cancer at the time of screening, not at the time of symptoms. So I really do endorse screening efforts, and by the way, I get my own PSA. So I'm not telling you different than I tell me. I get my own PSA, and I want to know that number. And that number gives me either some peace of mind or gives me the opportunity to think, what can I do to take care of this before it gets to be a bigger problem?
Sure. That's so important, right? It's you're walking the walk as a man who's at risk, and that's a pretty alarming number. As someone whose father survived prostate cancer, I recognize that, and I'm grateful for the research that you do and the work that you've done because he's here today to say thank you. And when I talk about screening and understanding the importance of it, like what are some of the risk factors that men need to start thinking about? At what age do they need to start screening? What does it mean for a man in Louisiana to say that prostate cancer is a risk they need to start thinking about?
There are three big risk factors. And the number one is the silly one, perhaps. It's age, okay?
That thing that hangs over our
head. Yeah, it hangs out over our head. Prostate cancer is pretty unusual under the age of about 45, and it increases as a function of age. And probably the average age in the patient in my clinic is about 68. But I see the whole range. Yesterday, I saw a 54-year-old. And very soon, actually yesterday, I saw a 54 and a 91-year-old.
Wow.
Yeah, so I've got kind of that range. By the way, the 91 was probably saying it's about to be 92. So, it's a big, broad range. African-American race, unequivocally related to risk of prostate cancer, as I alluded to, both the risk of cancer and the risk of death. So African-Americans are particularly important. Saw two African-American men yesterday in my clinic, and one of them has advanced disease under great control. The other one has had localized disease, and we need to go find it. We need better imaging to be able to go find it. So age, race, and family history. Don't we forget about family history. Family history is important. Your father and brother had prostate cancer, or mother and sister with breast cancer. Important for your risk of prostate.
That's an interesting risk that I think most people probably don't think about, but is very important to hear. So, so I hope everyone out there who's listening does take that to heart and speaks to one of their loved ones who may not know about it and share that risk factor.
Most people don't realize about the breast cancer, but if your mom had breast cancer, it makes a difference to your risk of prostate.
That's great to know. So, and we talked about this a little bit just now, but what advice would you give someone who may not be of age yet to start screening, but they're aware that they have a family history or may have risk factors, being of African-American race? What advice would you give them?
I like people to get their first PSA when it's going to be normal. And this is a little bit of an interesting concept. The later you wait to get your first PSA, the more likely it is you'll find a cancer that's already present and potentially growing. So the first PSA you get, you want to get it when the risk of cancer is very low, and then follow it over time so you can see changes and find something early. I typically recommend for somebody at higher risk to start at about age 45 to get a PSA test. And you might ask your physician may look at you and say, why do you want a PSA test? Because you said, I want to find it when it's normal. And it's important to do so. One of my colleagues who was very bright man, an MD, got his first PSA at age 57. And guess what? The prostate cancer was already there and it already spread. And it's like, wow, you could have gotten it earlier.
Sure.
No, so I started to get mine earlier, and I make sure that I follow that. It's not just the initial measurement, it's what happens over time too. So
Sure.
starting about age 45, if you're high risk, get a PSA.
Very important.
I like
That's great to know. Yeah, because we want to help people really understand the importance of preventative care and doing it early and not waiting until the symptoms arise, as you mentioned before. So you have focused a significant part of your career on improving quantity and quality of life for men. And, thinking about a man and going through this, I'm sure that considering the holistic care of a person plays a large role, even if they haven't gotten to the cancer stage, but even more importantly, when they're there. So what does that mean to provide holistic care to someone going through this journey?
I think the most important thing is to listen carefully to men and their preferences. It turns out within a variety of the prostate cancer stages, whether it be early or late, that there's some options that can be discussed. And getting full input and a discussion what the options might be. I try to keep people from being out of bounds. I don't let people do something wild and crazy. I keep them within the boundaries. But within those broad boundaries, there are different choices. And I try to make sure that patients are empowered to make that choice.
Sure. What is the outlook for someone who is diagnosed with prostate cancer?
Totally dependent on the stage. If you are diagnosed today with an early stage cancer and it's confined to the prostate, then our 5-year survival is 99%. Okay, really good. On the other hand, if you're diagnosed with metastatic disease, the 5-year survival is probably in the range now of around 65-70%. That's dramatically better than where it was. By the time you get to 10 years, if you have metastatic disease, that means the cancer spread into the bones or whatever at the time of diagnosis. 10-year survival is still kind of lucky. That's why we want to find it when it's localized. We can treat it and manage it more effectively when it has not yet left the prostate.
Yeah, so really important. I mean, still emphasizing that early screening because you have a better outlook on survival and even quality of life, I would assume. Quality of life is probably really good if you get it early and you can go on to your life.
The treatments for late-stage prostate cancer impact your quality of life more than the early stage. And so given a preference, I always want to find it early, then I can intervene, hopefully with a light touch, not always with a light touch, but sometimes with a light touch, or maybe even put people under surveillance, and then be able to intervene at a time when it's most appropriate. So there's a little bit of an art form there, but the bottom line is earlier is better.
Yeah. And it sounds like you're the great artist to do this work, to be the artist of the art form of really, the science and hearing the person, really addressing the need in front of you versus just...
Well, you have to have both.
Okay.
I mean, if you don't listen to the patient, how can you be a good doctor? If you don't know the science, how can you be a good doctor?
That's
you
right.
have to do both.
I love that. So tell us, what are some of the new technological advances out there? Things that are kind of cutting edge that we may not have had even 5 years ago that are truly impacting the way that prostate cancer is treated today?
Yeah, there are a couple of things that I'm excited about. One in particular is using what I call molecularly targeted radiation. So the cancer cells can express a protein on the cell surface that I can target with a radiation. It's kind of like, see the bullseye, and I shoot the arrow and hit the bullseye. One of the things we worked on is a compound, has a bit of a mouthful, PSMA 617, lutetium-177, and it's injected radiation, and then it finds the tumor and homes in and radiates the tumor very specifically. So we got an FDA approval on that a couple of years ago. We have another FDA approval this year. We have potentially another FDA approval coming next year for various stages of the disease. I'm excited about that. And we're starting to look at combination therapies. We're starting to look at earlier therapies. So that's interesting. Another advance that I'm excited about is a modification of immunotherapy. And it's not immunotherapy in the typical sense that people may see on television. It's a way to target the immunotherapy very specifically to the cancer cell, and it activates the immune system in a very local manner. Now, we can do this using some of the similar targets that we're using for the molecularly targeted radiation. We send an antibody in, and it's a two-headed antibody. One binds the tumor cell, the other binds the immune cell, and you get a local activation. We have an interesting protocol coming quite soon, experimental, but I'm excited about the early results on that.
Wow, all of that is a mouthful, right? And that it sounds very exciting that there's so much hope and so much evolution of care just, in your hands here in this city. So again, thank you for the work that you do. How have you seen the landscape of prostate cancer treatment and care evolve, not only in Louisiana, but across the country and over the course of your career?
Kristen, it's been pretty remarkable, actually. I started at a time when we had no therapies that prolonged survival for advanced prostate cancer patients. And we did hormonal therapy, which we've been doing for a long time. And then the patients failed the hormones, and basically there wasn't much to do. We've seen a remarkable transformation, not only in the hormones that we do use with the addition of better, newer hormones, but also by the addition of a whole series of other therapies that can help prolong survival. We mentioned the molecularly targeted radiation, the targeted radiation therapies. We have chemotherapies. We have new ways of approaching immunotherapy. It turns out that prostate cancer is susceptible to treatment, including targeted external beam radiation. And all of that is different than what we did 2 decades ago. So the field is evolving rapidly and in a good way.
Yeah, hearing 2 decades, that's a lot of evolution in 2 decades. So that, that speaks to the hope of the science and the research that you're doing, and to the men in this community and across the country, that there's so much more hope than there was 2 decades ago.
It is. And I just want to give a real shout out to the people who are doing the critical research, because without that work, we're not able to benefit the men with cancer. And there's been a huge evolution, and that's come from both academic laboratories, it's come from industrial laboratories. I've been able to play a small part here and there, and I'll simply say that it takes a big village to work on those problems, but we're making progress.
Yeah. Thank you. And you're caring for so many in so many ways. What do you do to care for your own well-being?
Well, I do become joyful when I'm able to help a patient with a tough problem. And it is a professional satisfaction. Admittedly, that's not my personal, but it really does give me huge satisfaction to be able to take care of people with this disease and see them do better, particularly when they have a complex problem that represents a bit of a challenge. So that's very nice to be developed.
Join us as we go beyond extraordinary on the 4th Tuesday of every month.